Hi, my name is K Henwood and today I'll be completing an anatomical analysis of stationary cycling for SPE262 functional anatomy. I'd like to acknowledge the traditional owners of the land in which I am recording from today, which is the Gubbi Gubbi people, and pay my respects to elders past, present and emerging. Stationary cycling was chosen due to the ease in which you can identify the movements that are seen. So it makes it easy to identify flexions and extensions, especially in the sagittal plane. So while the movements are easy to be seen as part of the cycling, the complexity of cycling occurs with the combination of all the movements together in the pedaling cycle. So the pedaling cycle is made up of 4 phases. So they're at the very top when your foot is directly at the top, it is called the top dead center phase. Then as it goes around the circle, we work into the power phase or the downward stroke. Then what it is at the very bottom of the circle with your foot is considered the bottom dead center stage before it goes back up into the recovery phase or upward stroke. So they're the phases of movement we'll be looking as part of the cycling circle. Some of the background concepts that are needed for this anatomical review are that of the use of anatomical planes. Planes are important because it helps all people understand where the location of something is in the body based on imaginary lines on a 2D image. So the main plane that we'll be using as part of this is the sagittal plane, which is the dividing between left and right side of the body with a plane line straight through the middle. Other planes include the frontal planes, which is like a line going directly through the front half of the body to separate the front and the back, or the anterior and posterior part of the body, and the transverse plane, which is basically a cut that goes through the belly button, which separates the superior and inferior part of the body, so the top half and the bottom half. So when we talk about directional terms, it's terms so that we can understand how things are moving in relation to space and where they are. So the main directional terms that are used in stationary cycling are that of flexion, which is decreasing the angle between 2 bones. So these are kind of more joint directional terms. So with flexion, so the arm coming closer, this is reducing the angle, so this is flexion. Extension is increasing the angle between 2 bones, so this is increasing the angle to 180. Also dorsiflexion, which is used in the ankle with the toes are now pointing upwards or superiorly towards the head, and plantarflexion, which is the toes pointing downwards. Other directional terms which are used in anatomy are things like anterior and posterior, so posterior towards the back, anterior towards the front. Superior and inferior, which we've discussed, is towards the head or away from the head. Medial and lateral, so medial is towards the midline or towards the belly button area. Lateral is away from, and proximal and distal. So proximal and distal is like closer or further to the trunk or the point of origin. So the trunk obviously being the torso midsection. Point of origin obviously is where the limbs come from the body. Also you've got abduction and abduction and adduction. So adduction is coming towards the midline of the body, and abduction is going away from the midline, and then rotation, so rotation of the joints along the axis. As expected in stationary cycling, the body segments that we'll be looking at most will be like the lower body segments, so like the hip, the knee, the ankle as far as joints go, a bit on the torso or the core, and a little bit touching on the shoulders, the elbows and the wrist, although they're mainly stationary. As discussed, we'll be looking at the 4 phases of the cycle of cycling. So we'll start off with the power phase. So the power phase is when most of the extension is happening. So in this phase, as you can see from the image, the hip is extending, so it is lengthening through there. And through that hip extension, it's giving power to push that pedal down. The knee is extending, and this is providing a lot of force. So again, the thigh bone and those degrees are increasing, and the ankle is going into plantar flexion. So it's adding additional power, and that's by getting those toes to go towards the ground. And that's pushing all of the power from those extensions and those muscles down into the pedal to create that force to make the wheels go round. Still in the power phase, if we're looking at the muscles that are creating the extension or extendors, and so forth. So if you look at the diagram on your screen, A in red is the gluteals, so they're generating downward force power. They're helping to stabilize the hips, which helps in maintaining that alignment of the hips, the knees, and the ankles, which gives that kind of smooth cycle as we go through. And it also gives you proper posture while you're riding, so that everything is staying in alignment and all we're doing is extending. And we're not going laterally or medially anywhere that we shouldn't, and it's all in alignment. Next, looking at B, which is the fuchsia kind of color, we're looking at the quadriceps. Now they're adding the most amount of power source towards a power phase, and they're like extending through the knee as that pedal is pushing down. And finally C, which is the salmon color, so we're looking at the calves, which are stabilizing the ankle, again helping to keep it all in alignment, and they're adding to that downward pushing through the foot. So the next phase we move to in the cycle is the bottom dead center. So the bottom dead center, as you can see on your screen, is when the foot is at the very bottom of the cycle, of the circle, or 6 o'clock if you want to use time. So highlighted in pink, you'll see that the hip is extended, nearly in full extension, however not locked. The knee, again, nearly fully extended, and that's highlighted in green, and the ankle is in plantar flexion or slight plantar flexion with the toes still pointing downwards. The reason that we don't want the joints to be locking or in full extension is because this can cause strains, and it's all about smooth transition. So this bottom dead center period is all about the smooth transition between the power or the extending of the joints to push the pedal down, and the recovery phase or the flexion in bringing the pedal right back up to the top of that cycle. So next we have the recovery phase. The recovery phase is when everything kind of goes back into flexion. It is when the pedal is coming back up to the top, and so probably from 6 o'clock to 12 o'clock if you want to talk about time. So the hip is entering flexion. So again, flexion, the degrees between the two bones is decreasing, and this helps bring the pedal upwards. The knee is going into flexion, and this again assists with the pedal lifting, and the ankle is lifting with dorsiflexion. So that is when the toes are pointing upwards. It's quite hard to see in this picture, but the toes are in a slight superior, so they're pointing upwards towards the head, and that's creating the lift for the pedal to come back up. Also, we're not using as much power through this, which is saving the muscles, so that gives us more longevity for them to be effective. When we're looking at the muscles which are helping to create that flexion in the recovery phase, or those decreasing in the joint between the bones, if we have a look at the diagram, so D, which is the blue color, which is anterior of the calf muscles, tibialis anterior. It also includes the extender digitorum longus, which controls the 4 toes of the foot and then helps bring them so they're superior, pointing upwards. And then we look at the extensor hallucis longus, which controls the big toe and make that come forward and upward, and the peroneus tertius muscle, which helps kind of control the foot from going outwards and so forth. Also, we look at E, which is in yellow or gold, and that is the gastrionemesis calf muscle. So it's posterior to the knee extension calf muscle. So towards the back, and psoas muscle, the iliacus, and the rectus femoris, which is in F, which is in the green, and that's kind of at the front. And that helps create the flexion in the hip. The final stage of the cycle, or the beginning stage again of the circle, is the top dead center. So this is where the foot is at the very top at the 12 o'clock position if we're talking time. So the hip is at flexion, the knee is at flexion, nearly maximum flexion, and the ankle, although it's hard to see in this image, is dorsiflexed. So those toes are pointing upwards towards the head. There is quite a risk at this with all of these joints in flexion, is that balance and stability and everything needs to be lined up, otherwise it can potentially cause throwing out of balance. So again, this is a transition point between the recovery phase and the power phase, so it's very important that the timing is sufficient with the other side of the body balancing out this. Next, we'll look at the segments of the body, so the trunk and the upper body. So very important for stability while everything is flexing and extending is that the spinal muscles, or the erector spina, are still keeping the core nice and strong. Those abdominal muscles of the rectus abdominis, the obliques, the deep transverse abdominis, and the pelvic floor muscles are all holding everything tight and controlled and balanced. The wrists, shoulders, and elbows have got minor flexion and extension for static balance. So it's considered static because we're doing the same exercise over and over again in repetition, and not doing heaps of movements forwards and so forth. There is a risk with improper posture and trunk stabilization. Lower back pain can occur if incorrect alignment of the hip, knee, and ankle, particularly in the knee with lateral movement or medial movement, then this can incur some injuries as well. You can see in this frontal plane on the picture that the knee, hip, and ankle are all in line, and that's to ensure the smooth, consistent force of going around in the cycle and the circle of cycling, and the consistent force is maintained as well as balance. A common injury in cycling is patellofemoral pain syndrome, or PFPS. The anatomy involved in this syndrome is the patellofemoral joint, which is located between the patella and the femoral trochlear groove. The body structures involved in this joint are the patella, or kneecap as more commonly known, which is a sesamoid bone embedded in the quadriceps tendon. The main tendons involved are the quadriceps, as discussed, and the patella tendon, which transfers force from the quadriceps to the tibia. So again, in the distal femur, which is where the trochlear groove is located, and that's where the patella tracks along the knee when it is flexing and extending in movement. And the surrounding soft tissue is also affected, which is the cartilage on the posterior or underside of the patella, and the retina calium. But as you can see from the example, when the knee is moving, which it commonly is with many activities, the patella can cause pain inside the knee if it is not correctly in the groove, or is there a reduced amount of cartilage, or there is inflammation from overuse and various other things that we will go into next. The key muscles involved in the patellofemoral syndrome is the vastus medialis obliquus, which stabilizes the patella medially, so across; the vastus lateralis, which stabilizes the patella laterally, so up and down in its position. Gluteals and hip abductors also help to keep everything in alignment. The quadriceps at the front of the thighs also assist in stabilizing the area. The plantar flexor muscles in the lower leg just help to keep everything aligned and balanced, and the hamstring at the back of the thigh is also part of issues that can arise from the patellofemoral pain syndrome. So if you see the diagram on the right, you'll see that there's actually a lot of muscles keeping the patella aligned, and that's because a lot of power comes from our knees. It's involved in a lot of movements, even basic ones like walking, squatting, and so forth, which we'll go into more detail with. And however, it cannot move immediately, otherwise it causes a lot of problems. Potential causes of PFPS is overuse. So the joint stress can be caused by overuse due to repetitive knee flexion and extension, which is quite possible in things like running and especially cycling, because you're doing the same movement over and over again with a high degree of repetitiveness of flexion, extension, and so forth. Biomedical causes could be the iliotibial band, which is the band that runs from the top of the hip and down the side of the knee to keep everything in a line. Could be pulling too tight, or the lateral retinaculum is pulling the patella laterally out of alignment. Could also be weakness in the vastus medalis obliquus, which could be pulling the patella to the side, so in a medial way, and the hip and knee out of alignment, which again could be from the iliotibial band or could be from other mechanical reasons, or injuries or sprains or strains, and maltracking of the patella so that it's not going into the trochlear groove like it's meant to with movement. So there's like grinding and so forth, and inflammation due to it not going where it should be going in the body with the movements. The pathology of PFPS includes cartilage, as previously discussed. So the articular patellar cartilage becomes damaged or inflamed, as visible on the right hand side. You can see the red area has become inflamed. This causes significant pain due to the amount of movement in that area. Maltracking, as previously discussed, so the uneven force distribution due to the patella not gliding correctly into the trochlear groove. Again, even a slight maltracking will cause significant pain in this area due to the high use. And chronic effects of this will be the synovial inflammation, the chondromalacia patella, which just basically means that the cartilage has thinned or started to degrade on the deeper side of the patella, so where a lot of the movement occurs, and this can cause like anterior knee pain and quite significant. Patellofemoral pain syndrome's repercussions for movements are quite significant. So obviously pain has a way of inhibition when it comes to movement, so it occurs when the knee is in flexion. Maltracking worsens due to pain, so this inhibition of not wanting to use it, not wanting to bend it, it just weakens the quadriceps activation. Daily tasks involving knee flexions that would be affected include sitting, walking, climbing stairs, using the toilet, squatting, kneeling, there's bending down, there's lots of different things that we probably don't realize how much we use it until it hurts, and then this creates a problem when we don't want to use that leg and we start putting too much effect on other muscles. So our gait or our way of walking, due to the discomfort, our walking gait can be altered, causing compensation challenges, including overall decreased function in the area because it hurts, because we're walking differently, the mobility isn't there, so increased imbalance, so there's like a lot more fall risks when our gait is different, our balancing of our body is different, how we walk is different. Secondary pain and strains in your backs, your hips, your ankles due to the imbalanced alignment, because we're not walking in the same way we normally would due to the pain, due to the inflammation and so forth. The patellofemoral pain syndrome's repercussions for movements and sports is again quite significant. So knee flexion is required for many sports, not just cycling. So running, jumping, basketball, hockey, soccer, volleyball, and even golf. Treatments include medications for inflammation and pain, rest, ice, compression, elevation, stretching and strengthening of the quadriceps and hips, obviously under support from allied health professionals, and supportive taping, bracing, possible orthotics. If it's due to something, you may even need surgical to improve if the cartilage is deteriorated beyond savability. But most of the time, we'll need to take a break from these sports because it is possible to damage the area worse if you keep on training with this pain in this area. The application of knowledge from completing this anatomical movement observation is we have noted the performance contribution of everything being in alignment. So the smooth hip, knee, ankle coordination allows for consistent force transfer. Correct techniques when cycling reduces wasted energy by having force and then the recovery in the cycle, and this allows for prolonged muscle use. So when everything's working as it should in alignment, then this allows for prolonged muscle use. Injury prevention, so again, poor alignment of the joints can lead to ankle overuse injuries. Otibial band stress, so again, the band that keeps the hips and knees in line together, and patellofemoral pain, which we talked at length about. Through the use of planes, so mainly flexion and extension. In the sagittal plane is where most of the movement occurred for cycling in this example, so to prevent stress to the body and maintain balance. The frontal plane stability through the hip, knee and ankle, all in alignment needed to be needed. So no medial movement at the knee. In the frontal plane, it needs to all be perfectly in line. And if this does have medial movement, this causes additional stress and affects endurance and performance when completing cycling. So for final reiteration of everything, so cycling was a clear example of movement in the sagittal plane. From the previous discussed slides, it was easy to see hip flexion and extension, ankle dorsiflexion and plantarflexion, and knee flexion and extension. So in the frontal plane, any misalignment of the hip, knee and ankle joints were really visible. Cycling involves a complex interplay of timing of body movements, of motor planning, coordination and balance. Through the use of anatomical directional terms and body planes, an accurate and universally understood communication can occur. So this clearer communication can reduce language perception inaccuracies between health and anatomy professionals. So it's very important that we're all speaking the exact same language. When we say something isn't working, then everyone knows why it isn't working and the way it isn't working and what movements are not working the way they should be working. So how does this anatomical analysis improve our understanding of sports performance and prevent injury? By us understanding how things work, by it being really easy for us to see when things aren't working properly, and for us to build performance in a way that we can make sure we're using the right amount of recovery and creating a space for peak performance, recovery and so forth, so that sports can get better and better and people with injuries and so forth can improve. Thank you for listening.